So for those of you that missed the YouTube live stream to discuss bispecific T-cell engager therapy, I want to thank you for joining and trying to learn about this therapy. So it's difficult to understand or appreciate the importance and the breakthrough that this technology means for cancer care without going through the history of oncology. So I just want to do a quick summary of where we've been for the past couple of decades. So I want to start off after World War I. There was studies going on with chemical warfare, nitrogen mustard. So two gentlemen out of Yale University, Dr. Goodman and Dr. Gilman, did studies with nitrogen mustard in lymphoma cells in mice and rabbits and subsequently treated patients and realized that it's an effective treatment. And to this date, we actually use bendamustine, which is a nitrogen mustard derivative, and we still use it to treat patients with lymphoma. Then Dr. Sidney Farber, a pathologist from Harvard University. You want to hear a little bit more about this story, you can look at the book or listen to the documentary in PBS, Cancer, the Emperor of All Maladies. Basically, this pathologist was using antifolate drugs. So folic acid is an essential nutrient for cells to survive. So drugs were developed, antifolate drugs were developed, and he was the first physician to actually use these drugs to treat kids with acute leukemia, inducing remission in some of them. The next I want to talk about Babe Ruth. So, famous baseball player, he suffered from a cancer called nasopharyngeal carcinoma. Very aggressive disease even to this date, difficult to treat. He was treated with antifolate and he did respond to therapy. And even though he ended up dying from his disease, he was able to enjoy one year of his life. He was treated at Mount Sinai in New York. More work came from antifolate therapy. Dr. Jane Wright did a lot of work on breast cancer. Dr. Hertz and Chiu Lee induced remission on a type of cancer called choriocarcinoma. This work came out of the National Cancer Institute. Some of the other drugs came out, 6-MP, anti-leukemia drug. Benca alkaloids came from a plant, also to this date used to treat multiple cancers, including lymphomas. And one of my favorites, Dr. Lawrence Einhorn. Now, this gentleman, it's a legend. So this drug came out to the scene in 1965, but it wasn't until 1974, at the young age of 31, he started using these drugs to treat testicular cancer without realizing that he was going to change cancer care for these patients. So he is in Indiana University, and he's still with us. So the cure rate for testicular cancer went from 5% all the way to 80%. And to this date, with some of the protocols that have been developed, could be up to 99%. Other drugs that have been developed, taxanes, 1990s, anthracyclines. So the way we look at these drugs is we consider them to be cytotoxic. So they work on malignant cells, impairing the proliferation. So mitosis is how cells replicate. 1 turns into 2, 2 into 4, 4 into 16 is an exponential. So some oncologists refer to these drugs as dawn bombs. So when you look at this picture here, you see a pilot in World War I looking down just to see where he's going to drop a bomb, and it's kind of like that, right? So when we treat some of these cancers, a lot of the side effects have to do with the fact that they affect the malignant cell, but they also affect the normal cells, and that's where all the side effects come from, right? So diarrhea, mouth sores, hair loss, etc. When I was in college in the 90s, I actually had the privilege of participating on what we call the Human Genome Project. So basically, we wanted to sequence all the DNA and the human genome and therefore potentially use that information to develop treatments, right, or understand how disease happened. So the project was estimated to take over 20, 30 years. It was finished in record time. And my contribution was some, but of course, me taking credit for any of this would be like having one bee fly up to you and say, I contributed to the stock of honey that's in the grocery store. I just had the privilege of working on this project, but it's very interesting how some of these things that I work on when I was in college later on translated, right? So today we're using something called NGS, next generation sequencing, where we actually determine genetic mutations within the cancer cell, and now we can decide what's going to be the best treatment. So the first drug that was developed and was targeted was Gleevec for chronic myelogenous leukemia. I remember working with these patients, and everybody was talking about, I want to go get the miracle pill that's going to cure this. Back then, patients lived 3 years. Now, 85 to 90% of the patients are alive in remission. So it's certainly a major breakthrough. So when you compare these drugs versus what we had before, you're going from dome bombs to the guided missiles, right? So next one is going to be your monoclonal antibodies. And I did actually, when I was in college too, I got to work with development of monoclonal antibodies. And these are molecules that bind to the cancer cell, and they send a signal to the immune cells. And now your immune cells can come in and start working on killing the cancer cell. The problem is that it sends a signal and the macrophages come in, but these drugs in general don't work very well by themselves, and you still need chemotherapy along with them. And there's a number of them. First one that came on the scene was rituximab, 1997, trastuzumab for breast cancer, alemtuzumab for chronic lymphocytic leukemia, cetuximab for colorectal cancer, bevacizumab for colorectal cancer, and for a while there was used for lung cancer as well. And that brings it to today. So today we have bispecific T-cell engagers. So these are antibodies that have two receptors. That's what bi comes from, bi2. One receptor is going to bind to the T cells. The CD3 bind to the T cells, and those are your cancer-killing cells. The other one binds to the cancer cell. So when you look at the screen, you will see that this is a T cell, and that T cell is binding to that malignant cell, and you can see how in this many steps it's hitting the cancer, hitting it, gets inside of it, keeps attacking the DNA, disrupting it, sending chemicals, cytokines to destroy the cancer cell. And towards the end of that video, you can see where that when the T cell is done attacking and killing that cancer cell, exits the cell, and now that cell shrinks like a prune and dies out. Fascinating. Now, how does that apply to real practice? So about 2 years ago, I made a career change. I decided to start a practice where my goal was to bring academic, university level treatment to the community. And that's when these drugs were kind of coming out. So we got the office certified, we got the nurses trained, and I did quite a bit of training. And for the past 2 years, I've been going to all kinds of conferences, learning from the experts that have been doing this on clinical studies and in private practice. How do you treat the side effects? How you prevent the side effects? And I've been fascinated by how effective these drugs are. So let me tell you, here we have a list of the drugs that have come into the scene. The first one was in 2014 for acute lymphoblastic leukemia, blinatumomab. Then in 2022, we have multiple myeloma drug, teclistamab, mosunetuzumab, which is for lymphoma, tebentafusp, which is for uveal melanoma. And then for 2023, we have more drugs coming out for lymphoma and multiple myeloma. 2024, the first bispecific T-cell engager for a solid tumor, small cell lung cancer, which is a very deadly disease. And 2025, we have more drugs coming out for multiple myeloma. So what cancer has been treated these days for with bispecific T-cell engagers? Well, we have multiple myeloma, diffuse large B-cell lymphoma, high-grade B-cell lymphoma, follicular lymphoma, acute lymphoblastic leukemia, small cell lung cancer, and uveal melanoma. Now, who are these treatments for? Well, typically in oncology, we tend to start doing clinical studies on those patients that have run out of options, and when the cancers tend to be the most difficult to treat, right? So typically these are patients that any line of therapy is going to either they don't have any choices or what's available has a 10 to 20% chance of working, right? So this is what we, by definition, call refractory disease. So the typical duration of response is short, right? So this drugs typically work for a few weeks, maybe perhaps a few months. But like Yoda said in Star Wars, always hope there is, right? So I want to tell you about our first patient. So this is a lady that was seen in a nearby practice, and this practice is just doing what's standard of care. They're providing treatments that everybody else has been providing here in Florida. But keep in mind that we started this project, so our mission was to provide academic university level care closer to home, and we were ready to start. We've been ready for 2 years, but being a young practice, we didn't have this patients. So this patients basically fell in our lap. So this lady came in and said, I can't travel far to the university. I'm by myself in Florida, and I don't have the means. So this lady have a disease called multiple myeloma, which is a cancer of the bone marrow, also known as, some people call it bone cancer. So this type of cancer produces protein, and that protein can go in, damage your kidneys, affect your bones, cause destruction of the bones, could form tumors. Now, your typical multiple myeloma patient will go into what you call a response or remission, and at least 50% of them are with controlled disease from the first treatment that they receive. They're controlled 5 years later. Now, this is a patient that within 4 years, she has received 4 lines of therapy. The last one was what you call the CAR T cells, and we might talk about that in another time. But she is what you, by definition, call refractory disease. So this was a very difficult case. So we were unexperienced at that time, so we wanted to do the admission to the hospital after treating her in the office, which is the way it was started in the clinical studies. So you start a dose, small dose. You make sure that the patient doesn't have side effects, and you escalate the dose. But after each dose, you put the patient in the hospital, just do observation. She didn't have anybody to stay with her in the hospital, so we tried one of these other lines of therapy. And as you can see on this graph, the cancer is getting worse, right? So that myeloma protein is going up. We tried that selinexor with bortezomib, and then it went down once for no more than, for a month, and then just spiked right up. And we said, no, we have to do this. So her sister traveled from Boston, stayed with her, and we started this drug called elranatamab. It's an anti-BCMA B-cell maturation antigen, and she, as you can see, had a very dramatic response. Actually, we got that myeloma protein down to normal range, but we noticed that within a month or two, there was slow but steady increase on that myeloma protein. So I'm thinking, so we're losing efficiency. We're not losing, like we're not having what you call a dramatic progression, but nevertheless just slowly losing ground. And there was some data combining another bispecific T-cell engager, and that's exactly what we did. So we changed to another BCMA agent. We added an anti-GPRC5D, and the combination of these two flattened that curve, and she's been down to in a flat curve, a remission state. So that's certainly very encouraging. So this is like nothing we've ever seen before, right? And this is not my opinion. When I go to some of these conferences, as we discuss these cases, that's basically what all these physicians and academics mention, is this is not like any other treatments we have seen. So let's move on to the second case. Now, this is the only one patient that we felt that the therapy failed, but did it really failed? So the patient was diagnosed in 2014, had a very refractory. I remember when I treated him back in 2014 in my old practice, the first line therapy did not work. We put him on clinical study back then, and the second line therapy worked, and then we sent him for transplant. And since then, he's been through multiple lines of therapy, more than 5 lines of therapy. So it's what you call a highly refractory case. So he came to us, another one of those cases. He did not have the means to travel to a university setting to get this treatments, and we were ready to start. So we treated him with this drug called elranatamab, an anti-BCMA. Now, when I started my training for these drugs, and when I say training is I go to as many conferences as I can. I talk to as many providers, and I still do, as I can, and I ask questions. So what if this? What if that? So back then, it was said that the blood test should, that's what I was at least trained back then, should not get worse while you're on therapy. And that was said more than once and by more than one provider. So within a month of therapy, his blood counts were deteriorating. His myeloma proteins was going the wrong direction, and we felt that he wasn't responding to that. So we changed him to another bispecific T-cell engager. So we changed it to a GPR C5D. And within a month of therapy, we also noticed that he was getting sick, and his labs were deteriorating. Calcium was going up. The kidney function he was going in kidney failure. His blood counts were going down. The myeloma protein, actually, I remember the last one we saw was more than 7,000. So it was like off the charts. Like the lab couldn't even measure the actual value. So we felt that it didn't work. So we stopped therapy. And when you stop therapy on patients and they have no more choices, you move on to what we call best supportive care. So we just try to keep those patients' symptoms under control. So I was giving him fluids to try to help with his kidneys, lower his calcium. And something very peculiar happened. Within 2 months of therapy, we noticed that his kidney function was improving. His calcium was going down. His blood counts were improving. For the first time since he was diagnosed in 2014, his platelet counts were normal. And I start to suspect that last treatment put him in remission. So what did we do? We repeated the myeloma protein labs, and his IgA went from 7,000 to undetectable. His light changed from over 4,000 to undetectable. We did a bone marrow biopsy, and as you can see on the report, no morphological involvement by residual myeloma. There were no plasma cells. So this was like when Han Solo rescued Luke Skywalker on that New Hope movie. So that's how I felt when we saw this. It's just like all hope was lost. He had what you call a late response. And since this happened, I've been sharing this story, and most of the physicians that I talk to in academics feel that this is an unusual case. Some other ones disagree. They disagree, and they feel that late responses have been well documented. So there's a little bit of, I think what made me feel good about this when I talk to some of these providers is we don't know everything about these drugs. So even some of the physicians and academics who have been doing these treatments on clinical studies, as experienced as they are, they acknowledge the fact that we don't know everything about. So I even question if we think that these drugs might work in, depending on the agents, 50, 60% of the patients. Perhaps the number is higher, and we have some of these patients have what you call late responses. Let's go to the next case. Now, this lady, 76-year-old with diffuse large B-cell lymphoma. Some of you may know these patients typically get cured from chemotherapy, right? And so about 20% of them don't for different reasons. But she was one of them that she didn't. So she's been through multiple lines of therapy through the years, for the past 10 years. And when she came in, she had 5 lines of therapy. And you can see the CAT scan on the left, where you can see all this lymph nodes that are swollen. I remember the day she walked into the office, she had this big tumor on her neck, and she said, look at this. And I knew right away what was wrong, and I said, don't worry about it. We ordered the CAT scan, but I also, at the same time I'm ordering the CAT scan, I'm ordering the bispecific T-cell engager therapy. So within the following week, we start treating her. And keep in mind that when you do these treatments, The first dose is typically low dose because you want to escalate the dose, go up to make sure that the patient tolerates it well, doesn't have too many side effects, and we'll talk about that shortly. And by the following week, even though this first dose was a small dose, that tumor was gone. It was just flat. And so the more therapies I do on patients, I realize how powerful these drugs are. Now let's talk about side effects. So there's a term called cytokine release syndrome. Cytokine release syndrome is when these cancer cells die, these chemicals from the dead cells get released into the bloodstream, and it could lead to low blood pressure, low oxygen. Now patients are short of breath. They may have a fever, muscle ache, joint pain. The other problem we can see is something called ICANS, immune effector cell-associated neurological toxicity. Now, this is a little bit more serious, right? So this could be just as simple as a headache. In some cases, patients get confusion. There's actually an algorithm that we follow. There's a series of questions to grade the ICANS, and we do this in our protocol. So it could range from headaches, confusion, weakness, feeling dizzy, speech impairment, and could even evolve to seizures. I think the key here is prevention, right? So it's almost like driving with your foot on the gas and a foot on the brakes. So you're killing cancer, now you kill too many, and too many of these chemicals get released into the bloodstream and making the patients a little too sick, either with the CRS or the ICANS. Well, you put the brakes with the dexamethasone, the steroid, to alleviate that response, and you slow it down. That gets relieved, then you get back. And typically, this potential complications happen only during the step-up phase or the ramp-up phase, and that's the phase when you're actually starting the patient on therapy in a low dose and you're bringing it up, and depending on the product, could be anything from 1 to 2 weeks to up to 3 weeks to finish up the step up. Now, in my experience and talking to more experienced physicians, we all agreed that the key here is to detect, that you train your staff to detect the CRS sign and symptoms and the ICANS sign and symptoms, and you detect early and intervene early. So early detection is going to save patients a lot of grief. You detect early, you intervene with your corticosteroids, and typically goes away and haven't had to step up to a more intense treatment. Now, what are the challenges with this? So the challenge is when this was first developed, right, was done in big academic centers with a lot of staff, a lot of resources to watch patients, and typically were either treated in the hospital, kept in the hospital, or treated in the clinic, and then admitted to the hospital for observation. So depending on the product, could be 24 to 48 hours. Then you need to have your office certified. They have what they call a REMS program. You need to train your nurses, the nurses in the hospital. We, the physicians, have to be trained. Now, there's some recent protocols that have been developed to treat, that show that you can actually treat patients, outpatients safely outside of the hospital. You can treat them in the office and then keep them outside of the hospital, but just do close observation. So we do provide our patients with a blood pressure cuff, thermometer, and a device to check their oxygen in their blood. And we have a diary. We watch them in the office after the step-up dose. And then we bring them back the next day or two, and then we keep a close eye on the vital signs, and we instruct them that if they have any problems, just to give us a call right away, and we give them a prescription for a corticosteroid, dexamethasone, to be taken at the onset of any of these signs or symptoms of the CRS or ICANS. In our practice, we actually provide the patients with the QRS code band. So they have it on the wrist. So if they have any problems, they're instructed to call us right away, start the dexamethasone. If it's after hours, to head to the emergency room. When they go to the emergency room, they can scan that QR code, comes up to the practice website. It will show them what the drug is, what CRS is, what ICANS is, how to manage it, and then we're coordinating with the emergency room. And as I said, early detection, early intervention, Patients are fine. I had to deal with CRS, ICANS, and patients, we have handled CRS as an outpatient. We had a patient with a temperature of 104, low blood pressure. She didn't want to go to the hospital. Dexamethasone, fluids, few hours. Within the office, she was fine, all good. We had an ICANS. I had to go to the hospital. Within 24 hours, went away with just single agent dexamethasone. And we kept them for another 24 hours just to make sure everything was okay. It was my first ICANS, and patient was fine. So what is the challenge right now? Access, right? So we don't have enough physicians trained for it, and we need more physicians in private practice to do it. I'm fortunate that I've been part of the American Oncology Network. So Dr. Brian Mulherin or pharmacy director Melody Chang, they put up this outpatient step-up program, and the company nationwide has given over 2,000 doses, right? So we're positioned now to move on to the next phase. What is the next phase? The next phase is clinical trials. So it's been estimated that anywhere from 50 to 100 drugs are going to be coming out within the next couple of years. It's believed that by 2030, 80% of the cancer care is going to include some form of bispecific T-cell engager. This past week, I was in a conference, and I met with several physicians and companies, and some of the clinical trials that we're looking to participate are to treat your most common type of cancer in men: prostate cancer, extrathoracic small cell carcinoma, non-small cell lung cancer, second-line therapy, myelofibrosis, colorectal cancer, cutaneous melanoma. The list goes on and on. The more therapies I do, I'm just fascinated by it. The more questions I have, the thirstier I am about trying to get the answer to some of this questions. But some of the things we have seen now is that there are some protocols using combinational drugs. So, for example, this past week, there was a presentation about using a bispecific T-cell engager with some of the conventional drugs for multiple myeloma, and the response rate, the chances that the drug is going to work, was 100%. We don't have that right now, right? So it's believed that some of these drugs are going to be moved to earlier. Right now, they're on the refractory side, but they're being studied up front. These actually were patients on first-line therapy. So that's what we believe the future is going to be. And we want to be part of it. We want to participate from those clinical studies. So what is the future? Clinical studies to use combination drugs, but we also know what these next generation bispecific T-cell engager is going to look like. And it's actually not bispecific, it's trispecific. It's going to be using 3 receptors. So 2 receptors within the antibody to bind to the cancer cell, and 1 to the T cells. But where does it end? I mean, could it be quad specific down the road? So very, very interesting technology. I've been privy to some of the data looking for those clinical trials, and the word that's been used around is a functional cure. What that means is that these patients are going to be cancer-free and be able to enjoy their life. We are interested in being part of the future. So not only what we've done is we proved that bispecific T-cell engagers could be given safely in the community. I'm glad to see that slowly we're starting to see some providers stepping up to the plate and providing the service. I think right now we have an access challenge in the nation, where physicians are slowly starting to do these therapies. It's just there's a number of factors, right? So you got to get your office trained, yourself, the hospital nurses, and it's just because it's new technology, just takes a little bit used to it. The reason we started up front is that, as I mentioned, it's just a career change that I have. That was my mission, just to bring those type of drugs and treatments up front in the community. Now we want to be part of providing those clinical studies, because when you do that, you provide treatment to your patients that is going to be available perhaps 2-3 years down the road, but you provide it now. And that it's what we feel is our mission. I want to thank you for joining us. And stay tuned.